Good morning. This is Dr. William Sonstein,
And I'm Rich Obedian.
and welcome to the third episode of the Spine Bros podcast.
Yeah.
You know what's interesting? People are afraid of spinal instrumentation. They fear it. People, they have no problem getting metal in their body for a hip replacement, knee replacement, ankle screws, wherever the orthopedic surgeons like to put in hardware. But when it comes to the spine, for some reason, there's a mystery to patients, and they have a problem whenever we say to them, you know what, I think you need to have some pins or some screws to help stabilize your spine.
You know, it's kind of irrational because there are really the top three fears that people have. Number one is fear of public speaking. Number two, fear of death. And number three, fear of spinal screws and instrumentation. And I think that emanates from,
Is that well documented somewhere?
I just made it up.
You just made it up
But
there?
it sounds good, doesn't it?
Oh, yeah.
But I think people have heard so many nightmarish stories about hardware and screws in the back migrating and moving and causing problems that they're terrified of spinal fusion in general. And especially when you tell them that it involves the insertion of pedicle screws and rods and all this carpentry, it kind of terrifies, it puts the fear of God into them. And they really want to avoid that.
But I think that one of the problems is that people don't understand, that they don't understand that the spinal cord does not travel down to the bottom. It
Correct.
ends at the upper part of the lumbar spine, usually what we call L1.
Right.
And that means that after the spinal cord ends, you just have a sack of nerves. And nerves are very resilient and resistant to injury, actually, believe it or not, if you are careful. But for the most part, I think that's what makes people so fearful, is that they're going to be paralyzed by whatever you do down there because they think the spinal cord is hanging out right there. And that's not what is not the case. That's not the way things are designed in the body. And I think that if people understood that, they perhaps wouldn't have such fear.
Yeah, I mean, there's a tremendous fear of spinal surgery for sure. You know, I do general orthopedics in my other daytime job, and when I suggest operations on the shoulder or the knee, people take that in stride. But when you talk about operating on the back, they're very concerned. They often want to see multiple opinions. They're very worried about what the implications of that are, and they're afraid of coming out paralyzed, or they're afraid of not surviving. You know, and I think that's because there have been so many bad stories in the media, whether it be Dr. Death, that got a lot of renown, who was a neurosurgeon in, it's always a neurosurgeon.
There was a neurosurgeon in Texas. Yes.
Who was I believe he's in jail now for various misadventures.
Well, he should be.
That they thought were that he basically admitted that he felt like he was God, and he was causing a lot of morbidity and deaths even.
He intentionally injured people.
Yeah, that's really a terrible thing. But in general, in the hands of a competent, well-trained, spine-trained neurosurgeon, orthopedic surgeon, those things should never happen.
We should I think, discuss what are the things that we do to ensure safety in the operating room, to put in screws and to do, when it's necessary to use screws. You know, people that come in, let's say, the classic reason and the most common reason that we usually use screws is if somebody has a misalignment of their spine and they require not only a decompression, but they also require a concurrent fusion. And, you know, depending on the patient's, condition, whether they're severely osteoporotic or whether they're very old or, what are their conditions, we will generally decide if we want to use screws or not. In people that have the classic condition of, let's say, for instance, an L4-5 spondylolisthesis, where they have a slippage of that vertebra, the L4 on a forward slip of the L4 vertebra on the L5 vertebra, they will very commonly have what we call lumbar stenosis, which is narrowing of the canal due to arthritis. I always tell patients when I think they need to have the screws placed that they should realize that the decompression is the hard part as far as I'm concerned. The actual placement of the screws is actually, in essence, I think that because you put in a lot of these things, it's the easier part of the surgery.
It is, it absolutely is. I think it's generally recommended, we recommend putting in the hardware when there's obvious instability. So cases like lumbar spondylolisthesis, but also you can create iatrogenic or instability that's caused during the operation when you remove a certain amount of the facet joints, and you can create instability in the operating room. And that, I believe, is one of the reasons why people are afraid of spine surgery, because in the old days, they would have an operation where they would have a wide decompression without a fusion, and then, sure enough, they developed instability because of the iatrogenic instability, and then a few months, maybe a year later, they needed a second operation. And as you know, anytime you do a second operation, there's more risk involved. The chance of infection is greater. The chance of spinal fluid leaks is greater. There's scar tissue. It's a much more difficult operation than when it's a version back. So I think if you're going to have the operation, you want it done right the very first time.
Done right the first time.
Done right initially. And there have been a number of studies in the orthopedic literature, the spine literature, that have shown that by adding the hardware, by adding the screws, the fusion rates are much higher. And you know, in the old days, in the 1950s, 60s, 70s, before there was pedicle screw systems and these new technologies that allow us to fuse the spine with instrumentation, spinal fuses were being done without hardware.
Right.
So now there are newer technologies that where the fusion rates are very high without putting in hardware.
Right.
You
we
know,
have a lot of materials now available to us that we hadn't had before.
Right. So some of those materials, you know, I think in orthopedic, as an orthopedic resident, you learn about osteoconductivity and osteoinductivity. And conduction is basically a scaffold that the bone can grow over, which is good to have. And induction is you actually cause the body to create new bone. So, you know, the gold standard for various bone grafts is your own iliac crest.
Right, which we don't take as generously anymore as we used to.
We still take it, but we use bone graft substitutes because it can cause morbidity by taking that iliac crest. It can cause pain. It can
Absolutely.
cause bleeding.
They complain more of the hip harvest of the bone graft than they did of the original surgery, these patients.
Yeah, absolutely. I mean, ACDFs, when I learned how to do ACDFs, or the anterior cervical discectomies and fusions, as a resident, we did every single one by taking a chunk of the iliac crest. And the patients postoperatively would complain more about that iliac crest site than they had preoperatively. So now we really use allograft bone or cages that are made of titanium that we can then fill with these bone graft substitutes. So there are a number of bone graft substitutes as well as the patient's own bone marrow, which has some inductive properties.
Right. So we use the induction, and we also use stuff that conducts the bone.
So some examples of stuff that conducts the bone are things like allograft bone graft,
right,
which is bone graft from a cadaver, from a dead person. You know,
that's been radiated.
That's been radiated, and it's been sterilized, and it's basically dead bone. It's been cooked at high temperatures, so the chance of disease transmission is infinitesimally small.
Right. Patients don't like to really discuss that too much.
No. Well, there was a scandal about 15, 20 years ago with one of the regeneration technologies, this company that was harvesting bone graft from funeral homes. And what they were essentially doing was they were going into poorer areas and taking bodies that were due to be cremated and, unbeknownst to the families, removing those bodies and basically removing their tibias and fibulas and all the bone graft, all the bone, and cutting it into little morsels, which could then be used for surgery.
Yeah, that's pretty
unethical.
Pretty unbelievable.
And they were using people who would never be a candidate for being a bone donor. So you know there were strict requirements in the United States for who can become a bone donor. And if you're beyond a certain age, you're not allowed to be a bone graft donor.
If you have certain diseases like
cancer,
hepatitis,
infectious diseases, AIDS, you really should not be a bone donor, and you'd be rejected. And these people were just in it for the greed, and they were because these bone grafts, these small pieces of bone graft, are selling for several $1,000s a piece.
It's very, very expensive. The market has exploded with this stuff.
Yeah, I mean they were replacing the bones with PVC piping and putting it back in, and nobody would know any better, but they got caught.
Yeah, that's not a good substitute.
And the irony is the guy who was in charge of it, I think he was a dentist.
Yeah.
He actually died of bone cancer, so that's karma.
Oh, that is kind of ironic.
Yeah. But since then, the FDA has really clamped down on these bone grafts, and they're really they're really safe.
We now use this material that I think it's pretty much become the community standard. It's called BMP. It's bone morphogenetic protein. It's basically a hormone that induces bone formation.
Right. So when you get a fracture, you break your wrist, you break any bone in your body releases a whole cascade of hormones to cause that fracture to heal. And the main one that induces new bone formation is BMP. And there's multiple different types of BMP. But the BMP that really causes the most bone formation is one called BMP2. And so there have been some companies, and now Medtronic owns the patent for it, which genetically manufactures pure BMP2. They put it on a collagen sponge in the operating room.
Right.
It's very expensive as well. It's about $5,000 for a little sponge of hormone.
A little thing you just wrap around the bone mass.
And you put your bone graft around that. Originally it was FDA approved for ALIFs, anterior lumbar interbody fusions, but since then it's been approved for posterolateral fusions that were non-unions.
Right. There was so a lot of the stuff is off-label use in essence.
The vast majority is off-label use, meaning that the FDA approved it for a specific use, but as a physician you can make the judgment call to use it for other uses that you deem necessary.
And it works. And we've seen it really over time. The fusion creation is fantastic.
It works like gangbusters.
You basically you take the bone material and you put it in over this little sheet. It's like a sponge, and the nurse applies the hormone onto it prior to doing this, and then you wrap it around, and it looks like a burrito shape. You want to keep the shape. That's the most effective way of using it, and you put it down on the bone and the environment you're creating. You want to create a fusion.
In the lateral gutters, right, over the transverse processes where you do the fusion.
So the fusion is not just putting in screws. It's also, the screws are just there to hold and to create a rigid system of the segments, to hold the segments together so that, like basically a broken arm, you're putting the arm in a cast that's broken.
Stop the motion and you'll get a faster fusion, faster healing.
And you put the bone down, and that fuses, and that's really once the bone is solidly fused, there's no more need for the instrumentation, but we don't generally go in and remove the hardware if there's not a problem afterward.
That's right. And then there's also another substance that we can use. There's some patients have heard about that whole scandal with the regeneration technologies and the bad bone graft that was being discovered, and they insist they don't want any bone from a cadaver, and oftentimes we'll use synthetic bone. And there's a company called Nanos, or a synthetic bone graft called Nanos, which is a calcium phosphate type of a bone graft, which is basically very similar to bone in its architecture, and the bone can grow into it.
Right, it's got a certain pore size that the bone.
Exactly. So it's very similar to normal bone, and since there were some other older ones that weren't as good, with ActiFuse and Vitas and other companies that we've used in the past, but I think at this point Nanos is the company that we're using the most right now, and that allows for a good scaffolding to allow the bone to grow into. It's really the patient's own bone that's growing over it.
Right.
That's just providing the calcium scaffolding that the bone can grow into.
We're basically we're recycling the patient's own bone when we do the laminectomy, where we have to remove the bone,
right.
And
So
we crush it up,
right.
And we separate the soft tissue. You don't want to put soft tissue into your bone, and they actually have a great machine now in the operating room. I don't even know how this really works. I have to look at it even more closely. But
separates the soft tissue from the bone.
Right, because the nurse used to be in the past have to take an instrument and actually strip off the soft tissue, which takes a long time, and it's very time consuming while she's trying to help you do what the main event of the surgery. So anyway, so this is why I worked with an orthopedic spine surgeon, because they're taught from the beginning how to basically anneal two pieces of bone together. So they know all the osteoinduction, conduction, all these terminologies. We as neurosurgeons were being introduced to this in the 80s and 90s, and really in the 90s, and then it becomes part of our language as well now, because it's been ingrained in us by working with orthopedic surgeons and learning about the fusion technologies. So So it's very important to understand this stuff, because this is a big part of what we do in degenerative spine surgery is not only decompressing but also fusing. So
yeah, it's a very fancy blender, basically, for lack of a better word, that removes the soft tissue and saves a lot of time of the scrub nurse from the scrub tech from having to denude the bone.
I think that's a big advance, frankly. And I mean, there's not been a lot of things that have really changed what we have done over the years. And one of the things that, besides the bone mill that is now used for separating, is certain types of devices that help us coagulate blood vessels, such as the Aquamanus, which is this giant, sort of looks like a bipolar, looks like a big forceps that, through ultrasonic means, basically shrinks the blood vessels and allows us to cover a wide swath of tissue to keep hemostasis while we're doing these big spine cases.
Right. It's not really a laser.
It's not a laser.
Patients, the Laser Spine Institute popularized laser spine surgery.
No, we have Ultrasonic Spine Institute now. We have the Aquamanus. It's a collation technique, which where water is basically heated by the ultrasonic radio frequency, and it actually doesn't get as hot as certain other instruments that we use, but it shrinks the blood vessels, and that's how it effectively allows hemostasis to occur. So that, to me, was a big advance in what we do surgically to really get down to blood loss.
Yeah, that's a tremendous advance. Yeah, there are other techniques we use also to minimize bleeding, like having the anesthesiologist lower the blood pressure. There's a number.
We like lower blood pressure.
We love lower blood pressure.
We're always arguing with them about that, too. They always want to keep it higher. We want to keep it lower. So we have to come to some sort of compromise.
Some sort of happy medium.
Right, exactly.
They're afraid of stroking out the patient if the blood pressure goes too low, and we're afraid of bleeding out the patient if the blood pressure is too high. So there's got to be a happy medium. There are precautions we take before any operation to make sure the patient has a good, successful, and safe outcome. Number one, patients get intravenous antibiotics before the operation to minimize the risk of infection. Number two, we have a neurological monitoring team.
The monitoring team.
Who is a critical part, and I think we should have them as a guest one day where we can discuss the specifics.
We will definitely get them as a guest, because I think it's very important, because I think that people, if they understood that what is being taken care of for them, like having a monitoring team there, I think they would feel better about getting the screws.
And the good thing about the monitoring team is they don't just monitor the lower extremities in the case of a lumbar surgery, but they also monitor the upper extremities, because when you're asleep, we position you on the operating room table, and inadvertently sometimes you can pinch the ulnar nerve and get numbness in your hand, or something else could be pinched unbeknownst to the surgeon, because the patient's asleep. They can't tell you that their arm is feeling numb.
That's right.
And we can reposition the arm in a way that it's not going to be pinching that nerve anymore.
That's a very important thing, because, I mean, there's nothing worse than having a very successful spine surgery and the patient's only complaint is numbness of their pinky, after the surgery.
Yeah, you're like, that had nothing to do with me. But really, what happens in the operating room ultimately is your responsibility. So you want to make sure that everything is in tip-top shape, and there's a much less chance of any kind of a nerve injury in any kind of a way.
So we have so basically in the operating room we have an electrophysiologist, a person who's been trained specifically to monitor the nerve impulses and the EMG, the muscle response to the nerves, and what we're doing in terms of monitoring the actual nerves that we're working near, and they can tell us if something's being affected or not. And then you have a neurologist, usually at a distant site, but still in real time, monitoring concurrently with the physiologist, and they communicate.
Right. And once we put the screws in, we can then actually test those screws and basically put an electric impulse through those screws and see if there's any excitation of that nerve that would indicate that pedicle or the wall where that screw is passing through has not been violated.
Right. There's a threshold that we use, and if it's basically below a certain threshold, then we know that either we have the screw has perforated through the bone. There could be a little crack in the bone that we just haven't seen by putting the screw in, because we're putting a screw into human bone, or the screw is too inside the actual path that we need to put the screw in, so we have to readjust this. By having that, we know what we're doing is safe.
Right. And we're also, and not only are we using the electromonitoring team to know if it's safe, but we're also doing that procedure under fluoroscopic guidance, under X-ray.
Real-time
Real-time
X-ray.
monitoring, and we're checking, and we're constantly looking at each other. We're talking to each other as the case is going. Move your hand up a little bit, move your hand down a little bit.
That's a very important point,
actually. Because sometimes from the other surgeon's viewpoint, you have a better angle of seeing exactly where that where that hand should be going, and it's really only a matter of sometimes centimeters that you're off by, but that's useful advice, and that's the other advantage of having two spine-trained surgeons in the operating room, to help guide each other.
It's a check and balance, it really is, and that's the great thing about putting screws in with you is because, we're always looking at each other's work. You're putting your screws in, I'm putting my screws in, but still we're putting our screws in together, basically.
Absolutely.
And we're always saying, okay, that looks good, or maybe you want to drill a little higher, and readjust that position of that hole you made to start the screw placement. And I think by having that, and we're always checking X-ray, we're always looking at front views and side views to make sure what we're doing is correct. So when we leave the operating room, we feel good about what we just did.
So there's really three levels. One is our own looking at it directly with our own eyes, feeling it. So basically, once you make that hole, you put a probe into that hole to make sure that it's surrounded by bone, and then checking on the X-ray device, and then finally doing the EMG monitoring, where you can stimulate that screw and see if it's reached the appropriate threshold. Now, sometimes patients will have, there's no specific number that you want to hit. Generally, the lower the number, the worse it is. But some patients have very bad osteoporosis.
That's right.
So they might get a lower number, even though the screw is placed perfectly. You might have a lower number than you would in somebody with much harder bone or less osteoporotic bone.
And what do we do?
And we'll take that screw out.
That's right.
And ensure that it's definitely in. We'll double check it.
We'll take a probe and we'll stick it into the hole we made with the screw, and we'll feel around
and to find if there's any defect or any slight crack that we did not notice before. And if it looks good on the X-ray and you're getting a decent bite. Now there are also different screws that we can use when the bone is osteoporotic to make the fixation better, because you don't want that screw to get loose.
We actually have special
dual core screws
that have a change of pitch as you apply it, and you have some screws that are actually made of material that actually is specially designed
that
for
have hydroxyapatite coating on them, which is like similar to the bone graft substitutes.
Which helps the fixation of patients who have osteoporosis, and we can know beforehand by getting bone densitometry to evaluate how osteoporotic this patient is.